My name is Thomasine Kelley. I am the HIV STD Nurse Program Coordinator for the Arkansas Department of Health. This presentation today will be on the ADH role in syphilis management. I want to start by saying that we are very thankful for the partnership and the collaboration with ARPQC in our team efforts to change the direction and the outcomes of this syphilis crisis. As you are all aware, we are in the midst of a national syphilis outbreak that is directly affecting Arkansans. This crisis is disproportionately affecting pregnant women and their babies. We need to be vigilant in addressing this issue because, as Yomi stated in her presentation, congenital syphilis is totally preventable and babies should not be dying of this infection. During my portion of this presentation, I will walk you through what typically happens when a positive syphilis report is received by the health department. So let's start with provider reporting. Arkansas is a dual reporting state, which means the ordering provider and the testing laboratory are both required to report all positive syphilis test results to the Arkansas Department of Health. By law, a positive syphilis test during pregnancy must be reported, and this applies each time the woman becomes pregnant. Most of the major hospitals and laboratories are set up to report through the electronic lab reporting or ELR process, which means the positive report for that facility is automatically reported electronically rather than providers having to submit that report manually. The providers who do not use the ELR process must report the information manually using the communicable disease reporting form, and this is what the form looks like. The reporting form can be accessed through the ADH internet site at www.healthy.arkansas.gov. This form is used for syphilis plus all other reportable communicable diseases. The fax number to send the report is 501-661-2428, which is highlighted here. We also have a fax number designated for syphilis reports only, and that number is 501-661-2035. And either number is fine to use when reporting syphilis. Basically, you can just go to the website, download the form, and enter the required information, then fax the report to report your case. One thing for the ordering providers to keep in mind is that the treatment information is part of the reporting, and laboratories typically do not have this information, which is needed. So here's a map of Arkansas that outlines our 5 regions. We have 95 local health units across the state that test and treat for syphilis and the other reportable STIs, which are chlamydia, gonorrhea, and HIV. We have disease intervention specialists, or DIS, in each region who investigate the reports of syphilis. We also have a couple of congenital syphilis DIS who focus specifically on pregnant women with syphilis and their newborns at delivery. I will give you more details about their roles in a few minutes. So the process looks like this. When a provider reports a positive syphilis test electronically or manually to ADH, the information goes into the surveillance database, which generates a field record that is assigned to a DIS. Syphilis is one of our high priority STIs along with HIV. So when a syphilis report is entered into the system, the DIS will begin their investigation within 1 to 2 business days of receiving the field record assignment. One of the first things the DIS will do is verify the pregnancy status. If a woman is pregnant, the DIS will notify the congenital syphilis DIS and the program nurse, which is me, so that we can begin the tracking process that will continue throughout the pregnancy and delivery of the baby. The specific activities of the DIS include a record search for testing and treatment. If the patient reports a history of treatment in another state, we can reach out to that state health department and request testing and treatment history information. In order to request out-of-state information, we have to know the specific state to check because there is no national database to check all states. The DIS will also reach out to the state's medical provider for history of signs and symptoms of syphilis, treatment information, and testing history, including negative test results. Information regarding signs and symptoms and test history is relevant for determining the stage of syphilis and the treatment needed. We utilize SHARE and the infection preventionists in hospitals as resources, as well as contacting the patient directly to gather necessary information about the history and their partners. Partner services is a critical piece of this process in that if we don't get partners tested and adequately treated, we can't effectively prevent congenital syphilis because of maternal re-exposure to untreated partners that lead to reinfection. The DIS enlisted support of the patient's providers, as well as phone calls, text messages, and emails as a means to contact patients and their partners who need testing and treatment. In some cases, the DIS will make a field visit to try and locate a pregnant woman who needs treatment if they are not able to contact her through the other methods. We want these moms and babies to receive adequate treatment in a timely manner, so the DIS may also provide transportation to and from the local health unit or OB provider as a last resort for a pregnant woman who needs treatment if she's having difficulty getting in or keeping appointments due to transportation issues. The transportation is limited to pregnant women with syphilis and does not include other patients. The DIS also help facilitate priority appointments to the local health units for testing and treatment of syphilis patients as well as their partners. As I mentioned earlier, pregnant women with syphilis is one of our highest priority groups. So we try to get them in and their partners an appointment within 1 to 2 business days. Now let's dive a little deeper into the role of the congenital syphilis DIS, also known as CSDIS. The CSDIS work directly with me and track all pregnant women diagnosed with syphilis from the time we receive the notification until the delivery of the baby. The CSDIS utilizes the ADH medical record system, the pregnant woman's OB provider, SHARE, and infection preventionist as resources to verify treatment. If we are unable to verify adequate treatment, we assist with getting the mom into local health units for treatment within 1 to 2 business days. If the mom prefers to receive treatment through her OB, we follow up with the provider to verify treatment is received. After adequate treatment is completed and verified, the CSDIS will check the medical record or follow up with the OB monthly to monitor the RPRs throughout pregnancy to ensure appropriate serologic response to treatment and that there are no indications of reinfection, such as a 4-fold increase in the RPR titer. If the CSDIS determines that there is a significant increase in the RPR titer, we will notify the provider and also reach out to the patient to help get them in for reevaluation and retreatment if necessary, hopefully at least 30 days before delivery of the baby. We will also reach out to the provider and the patients when we are aware that they have missed appointments for treatment or follow-up syphilis testing. We monitor this on a monthly basis for all pregnant women that we are aware of in the state. For infants exposed to syphilis in utero, we will track them for up to 6 to 12 months by reviewing their medical records as well. We look for RPR results, CSF testing, long bone x-rays, and any documentation of clinical signs and symptoms of syphilis. We also verify that they have received adequate treatment according to the Red Book recommendations or recommendations made by the Arkansas Children's Hospital Pediatric Infectious Disease Clinic, if they are involved in the consultation. Whenever there is a baby outside of the Little Rock metro area, we will also help link those pediatric providers to the ACH providers when needed. For the newborns who receive follow-up testing by the pediatrician after delivery, we will continue to review the medical records about every 2 to 3 months for up to 6 to 12 months until we verify that there are 2 consecutive non-reactive RPRs. And just to clarify, the infant testing is typically done by the infant's doctor, not by ADH. Our responsibility is to review the medical records for results and collaborate with providers and potentially catch any infants that may fall through the cracks. If the pediatric provider decides that the newborn only needs one non-reactive RPR instead of 2, then we will stop follow-up of the infant at that time. Since the bicillin shortage has been resolved, we do have sufficient supply of the medication to treat patients and their partners with bicillin, since that is the preferred treatment recommended by CDC. For providers who have difficulty getting bicillin due to cost, storage, and other challenges, we welcome you to refer your patients and their partners to one of the local health units for treatment with bicillin. It is helpful to provide that patient with a copy of their positive test results, just in case a local health unit doesn't have immediate access to those results, and this could prevent a delay in treatment. One of the limitations that we have at the health department is that we cannot provide desensitization for someone who is allergic to penicillin. However, if the patient is desensitized by another provider and receives the first dose without any issues, we are able to administer the second and the third doses if needed within the 7 to 9 day interval that is recommended by CDC. Another limitation is if there is a suspicion for neurosyphilis, the patient has to be referred to another medical provider for further evaluation of neuro involvement. And if the symptoms are determined to be neuro, ocular, or otic syphilis, we cannot provide the IV treatment for the 10 to 14 days as recommended by CDC. So here is the contact information for me and my team, should there be any questions or need for consultation about syphilis cases. The DIS and the congenital syphilis DIS are not clinicians, but they are a great resource and are able to assist with historical information related to testing and treatment. The two congenital syphilis DIS currently on staff are Stephanie Lovell and Misty Petty Wilson. Here is their contact information, and you can reach out to either of them with your request. This wraps up my portion of the presentation, so I will now turn it over to my colleague, Mallory Jayroe, who is our infectious disease epidemiology supervisor and the SETNet coordinator. Thank you so much for your time and attention.
Thank you, Thomasina. And yeah, if you just want to advance my slides, that'll be great. So again, thank you to the Arkansas Perinatal Quality Collaborative for doing this pilot. It is so appreciated. And I'll kind of echo what Thomasina said. You know, we're currently in a syphilis crisis, and we're doing a lot of the health department, and we're just so thankful for this collaboration and all of you to do this in your hospitals and really try to prevent syphilis and congenital syphilis in Arkansas. Next slide. So this is just showing, if you were to put play on the graphic, this is showing basically primary and secondary syphilis rates reported among cases for women age 15 to 44, which is reproductive age. And you can kind of see where we started at first at 2012 up until now. And so you can see it's not only an Arkansas problem, it's a United States problem. Next slide. This is a report from the CDC. They looked at all county data for rates of primary and secondary syphilis among women of reproductive age. This is from 2021, and we actually just got the 2023 data. And there's like good news and bad news. So as you see in the top 20, and I would like to point out, this is all counties in the United States. So the fact that Arkansas has 5 counties that popped up as one of the highest rates is not something that is great, but we again are working towards getting these numbers down. So St. Francis, Dallas County, Mississippi, Jackson, Hot Springs County, all were in the top 20 in 2021. And like I said, the 2023 data just came out back in like November of 24, and we're analyzing that and trying to put a report together. But with the data, we actually saw that we are not in the top 20, but that's the good news. But the bad news is we're not in the top 20 because everyone else is doing worse. So South Dakota is pretty much leading, and Montana with the syphilis rates, and so their numbers increase. And then but if you look at our rates of those that from like St. Francis and Mississippi from back in 21, they're pretty much the same rate. But again, we're not in the top 20 anymore. We're in the top 50. But again, our rates haven't improved, unfortunately. It's just that everyone else around us is going up. Next slide. So this is pulled straight from our dashboard. The Department of Health has a rate of early syphilis cases by county. This is just again pulled from the dashboard, and you can kind of go to this interactive map, and I'll have a QR code at the end, and you can just type in ADH Data Hub or Syphilis Data ADH, and this will pop up. But you can actually hover over your county and see your case rate, as well as how many cases you had if it's not suppressed. But in 2023, we had around 1,400 early syphilis cases, and this is also broken down by demographic and things on the website. And we also have different presentations breaking this down if interested. But you can see that though we only have around 1,400 cases, this is all that we know about. I want to echo what Thomasine said. This is what's reported to us. We do know from predictive modeling and just kind of the cases that this is probably higher than what we actually are seeing number-wise due to the ineffects of testing and things like that. That's why we're encouraging testing and things like this. Yes, this is not congenital syphilis. This is just early syphilis, and we're going to get to the congenital syphilis in the next slide. Next slide, please. So this is congenital syphilis rates per 100,000 lab births in Arkansas. And you can see from 2012 to 2022, we had a 562% increase in the rate of congenital syphilis. So this is obviously why we even started this initiative, why, the Arkansas Perinatal Equality, why they reached out to the Department of Health to really collaborate on this pilot because of our rates. And you can see, again, 562 increase of congenital syphilis when, as we know, congenital syphilis is preventable and should not honestly be having this higher rates in 2025. Next slide, please. And you can, just put all the pictures up. So when I talk about the data, I really like to also, I know you all are providers and work in the healthcare setting, but sometimes I just like to reiterate, because I sit here and talk about congenital syphilis and syphilis all day long. Sometimes I forget the impact congenital syphilis has, and that is adverse effects like Hutchinson's teeth. You can have rashes and in these mucus patches. These are some of the things that, a mom could have a completely normal pregnancy and deliver a baby that has these abnormalities and defects due to congenital syphilis. Next slide. And of course, the saddest part of congenital syphilis is the stillbirths and infant deaths. And this is from 2012 to 2021. And you can see that the number of stillbirths and infant deaths due to congenital syphilis. This is United States, but in Arkansas, we have had deaths and stillbirths related to congenital syphilis, and we have that data at the health department if you're interested in seeing that. Next slide. So one of the things we do at the Department of Health is, again, everything Thomasine talked about, then we as the epi team, myself, as well as our STI epidemiologist, Kylie Chisholm, we look at the data and analyze it to kind of see what's going on. We, us along with the CDC, looked at missed opportunities, and this is missed prevention opportunities among mothers delivering infants with congenital syphilis, and this is 2022 to 2023. And you can see the highest was non-timely or no testing. So this is two things. Either one, the mom didn't get any prenatal care, or she did get prenatal care and there was just no testing done for whatever reason. We also have inadequate treatment. So we see a lot of the times that sometimes providers are not doing the accurate treatment. Maybe they only gave one shot when they needed 3 and things like that. And then we also see that if the mom comes in too late, there wasn't enough adequate treatment to give before she had birth. And then one of the things that has been popping up recently that has been of concern is the late identification of seroconversion. And so what that basically means is reinfection. So sometimes these moms are getting to the provider, are getting tested and getting treated, but their partners aren't being treated, and then they get reinfected, and then the baby will be born with congenital syphilis. So we are seeing an uptake in reinfections among our moms. Next slide. And so this was done by the CDC. I'm sure if y'all have paid attention, not only in Arkansas, but in national news, has been a really big concern out of Washington is syphilis. They had created a syphilis task force that some of myself and Thomasine and other Arkansas companions sit on. And they have really been focusing and trying to put more efforts into syphilis and congenital syphilis. This was done by the CDC, and it just shows that timely syphilis testing and treatment during pregnancy might have prevented almost 90% of the cases. And that, again, echoes what we see in Arkansas as well. And you can see they kind of echo our data, which is 40% inadequate treatment and 37% no timely test. Next slide. So that's basically just like a rapid fire of just some data and kind of what we do at the health department. We have been working tirelessly for almost 2-3 years now, pushing out reports and things like that. And those can be found on our website. We actually have a congenital syphilis and pregnancy on our website, and just information as well as other resources, including some of this data I presented. And if you want any more data or you're interested in your certain county, you can reach out to myself or Kelley Chisholm, and they're for data request, and that's our information right here. This QR code goes to our dashboard, and of course, for any clinical questions, you have Thomasina's information, as well as Nick Butler, who is over our DIS that Thomasina talked about. So again, this is kind of like the part 2 of what we do at the health department. On top of what Thomasina does, we kind of do the data and kind of see where our efforts are needed to address syphilis and congenital syphilis. And that is all I have.